I would like to invite Dr. Anubhav Goyal. He'll be talking to us about approach to the posterior segment trauma, understanding primary repair and secondary management.
So, first of all, I'll say thank you, Dr. Vaneshri, for giving me this opportunity. So, my topic is on posterior segment trauma. So, most common important point in posterior segment trauma is meticulous closure of scleral wounds, which is very important for open globe injuries. As far as closed globe injuries are concerned, closed globe injury, if there is visible retinal break or an obvious retinal detachment, only those cases need to be operated immediately or intervened immediately for retinal breaks with retinal lasers. Otherwise, all cases with attached retina, you can conservatively treat and wait until the media get clears to intervene further for the posterior segment. So most tricky thing is when there's open globe injury, how to intervene, what to intervene, which test to be done prior and which test to be done later on. So I'll be dealing most commonly with open globes. So all these posterior segment traumas, basically zone 2 and zone 3, it can be occult or manifest. We have to see there can be presence of intraocular foreign body, or there can be presence of infection or endophthalmitis at the time you have seen the patient. So you have to very carefully see which zone is involvement and what is the present status. Foreign bodies in a very badly damaged eye with a lot of hemorrhage in AC and posterior segment, it's difficult to see. For that you need imaging. So goal is to restoration of integrity of the globe and avoidance of further injury to the underlying ocular tissues. So for very small scleral wounds where there is not much leakage, where there is a small wire like a wire injury in the eye without much uveal prolapse, where you are seeing not much of tissue damage is there, you can just manage conservatively with antibiotic drops, and it will heal because of the tenon's support. When you feel it's a bigger injury, whether it is occult or manifest, you have to, if it is manifest, you are very clear, you can take the patient. But if it is occult, the signs of occult skull rupture are when the eye is very hypotonous, when there is massive intraocular bleed, whether it's massive anti-chamber bleed or vitreous hemorrhage, massive subconjunctival hemorrhage where you are not able to see any the sclera, or massive lid edema which is obscuring and giving an eye very soft texture. So in this, globe exploration is mandatory. You cannot just leave the eye like this. Globe exploration is mandatory, depending upon the appropriate anesthesia you are comfortable with. I prefer to operate these cases under general anesthesia, and special attention to be given to the areas of muscle insertion in these exploration, because these are the thinnest areas from where the globe perforation will be most expected. So the important pulse is the dissection of conjunctiva and tenons should be done from anterior to the posterior extent of the globe. There's a video showing you have to nicely open up tenons conjunctiva and explore whole maximum length of the tear, and after confirming the posterior most extent, if you start that time, it will be better. And the first suture will be which should be, if it is a limbal involving tear, first suture should be on the limbus. First suture should be taken on the limbus to maintain the anatomical integrity of the globe, and other sutures can be taken at the other lacerated most prominent anatomical landmarks, so to maintain the aligned anatomical integrity. For scleral sutures, that Dr. Sogaranjini told, 70 vicryls are best. For corneal, anyway, she has told very nicely. So interpreted sutures are preferred sutures to be done in scleral perforations. This is a video showing how we have to take these interpreted sutures, first at the limbus and others at the sclera. So the suture should be the deep scleral bites, so that the maximum sclera can be taken without much underlying tissue exposure. You have to keep in mind to avoid damage to the underlying tissue, especially choroid, because if you engage choroid, your patient might land up into sympathetic ophthalmitis in the other eye later on. So tubular tissue and underlying tissue like vitreous and retina also be taken care of. So this is a diagrammatic presentation in which it is shown that the first of all limbus has to be sutured, and then along with that cornea, anterior segment, zone 1 and zone 2 has to be sutured. So after that limbal suture, the most prominent lacerated zones like this angle has to be sutured, so, and this second angle has to be sutured, so that the globe positioning will be better. Then further on you can give sutures in the intermediate areas. So the best thing is close as you go. First of all, suture in the anterior part, and those slowly expose the posterior part and go slowly to the posterior most extent and close on the go. If you are feeling a little bit difficulty in exposing, you leave a long suture end at the trailing suture, so that you can use that suture to pull the eye and expose the posterior part of the wound. So very important is, should not cut blindly whatever is exposed from the wound. It can be uvea, it can be retina. So if you examine the wound properly, if it is retina and uveal tissue, you have to reposit it. If you are seeing vitreous, you can remove it, cut it, and amputate and suture the wound. And if the muscles, if the wound is this is fourth pole, if the muscle, the wound is extending below the rectus muscles, you have to disinsert the rectus muscle to see carefully the extent of wound, and you have to reinsert them muscles later on. Okay, and if the wound is very posterior, you are not able to see the extreme posterior most extent, you can leave it, but then as far as possible try to expose the posterior most location and suture it as far as possible. Should not leave any open edge of the tear. So so this is intermittent. So it's very mandatory, if you're seeing any necrotic or infected tissue, you have to remove it nicely, so that the chances of post-op infection can be avoided, and intravitreal antibiotics can be given at the end of the surgery to avoid post-op infection. I prefer to give antibiotics in all the open globe injuries, especially posterior segment involving. If it is a very large scleral tear, if there is a tissue loss, you have to use a graft material. Best will be homologous scleral graft, patch graft. You can also use split thickness dermal graft. So and this is a video showing nice exposure of conjunctiva and tenons starting from anterior to posterior. Whole length has to be exposed, and you can start suturing close as you go technique from limbus to the posterior extent, and interpreted suture has to be given with a nice closure. Then muscle is disinserted, so see the posterior extent, and nicely sutured all the tear wound, and then muscle is later on reinserted, checking the wound whether there is any leakage or not. After confirming the whole extent of the wound, only then you have to close the eye. Then only it will give a good integrity. Otherwise, it will end up into phthisis or other complications later on. So this, So in this here, I want to stress, if the eye is very badly traumatized and there is no view, you have to do primary closure as soon as possible. You should not wait for CT scan or B scan, because delaying delaying for the imaging might create more chances of infection. So that anyway, we are not going to intervene for any other thing in the primary surgery, and CT scan or B scan to confirm the retained intraocular foreign body can be done on the later date. But if there is a good view, then obviously you have to image as soon as possible, so that in case you need to remove the foreign body, you can do it on the same surgery. So this is a case in which the view was clear. This is and there was a thick iron 6 mm iron metal piece injury in the eye, where you can see a scleral wound, entry wound, which here is exposed and initially sutured nicely. This was self-opposing wound, but I sutured it, and then 3 pars plana ports were made. I fastened the video. Vitrectomy started, and then see this foreign body is disengaged from the inferior part of the retina. Vitrectomy is completed, and vitreous has to be removed from all edges nicely. You should not leave any vitreous at any edge. Then a big scleral entry opening has to be made, bigger than the foreign body size, so that it can be easily taken out. It should not fall back. It should not get engaged in the pars plana. This is a rounded edge foreign body. It was difficult to take it out for forceps, so I take it out with magnet, and I opened the wound with a forceps so that it should not fall down. You see that I'm holding this wound and slowly taken out the foreign body. It should come right in toto without breaking into pieces. Scleral wound should be closed like a normal perforation and with interrupted sutures. And then later on there was a inflamed vessels which should be lasered. Then this is the retinal tear which was there, which was cryo treatment was done to prevent chances of retinal detachment in the future. This should be done. And then depending upon the tamponade you can prefer. I prefer to give oil in such cases because of chance of recurrence, retinal detachment in future. And also additionally I prefer to give cryo at the edges of scleral tear repair. So this is the main crux is intervene and intervene as soon as possible in a posterior segment trauma to prevent infection chances postoperatively. Imaging can be delayed for next day to confirm intraocular foreign bodies, but if media clarity is good, you can intervene on the same day with the imaging.
Thank you so much, Dr. Anubhav. Any questions? Yes.
Yes, sir.
Earlier we used to say there is a golden period, like any uveal tissue which is prolapsed outside. If it is less than 4 to 6 hours, you can, reposit it. Otherwise, you have to abscise it. Does it still hold or?
No, sir. Now we are not trying to excise it because it's chances of hemorrhage and RDs are more. Now, unless we are seeing any infected tissue, we are not excising it. We are just repositing it. We should now reposit it. We should not excise it, and we have to close it. Anyway, now as a golden rule, we are giving intravitreal antibiotics with all the posterior segment trauma. So that is the second way to prevent the infections post-operatively.
Second, you said you can remove the vitreous. How do you do it with like normally with a Vexel sponge or something like that, or you use a vitrectomy cutter?
Vitrectomy cutter is best, sir, because it can precisely trim out the vitreous.
Yeah, and
but if
it doesn't pull.
It doesn't pull.
Yeah.
Otherwise, if you use the bird and your Vanas scissors, it will pull the vitreous. We should not pull any wound. Any tissue under deeper tissue should not be more pushed out from the wound. You have to close the wound. That's why all these open globe injury, if it is a large wound, prefer to operate under GA. Should not give local anesthesia. That is an additional thing I wish to say.
Thank you. That's a wonderful talk.
And so one question. So for simple, sometimes we have these very small scleral tears, not very large ones. But when we are doing the repair, the uveal tissue will just keep coming into the wound when we are taking the bites. So any tips that you can guide?
Yeah. So in this wound, instead of taking from anterior lip, from the anterior lip to posterior lip, I will prefer to take first bite in the posterior lip and then second bite in the anterior lip, so that the knot will come in between the lips and it will also push the wound uveal tissue beneath. Okay. If you take the suture bite from anterior to posterior lip, it will, there are high chances that it will engage the uveal tissue and come out, and then needle will come out in the wound.
Okay. Okay. Thank you, sir.
Okay. Yeah. Yeah.
What is the time interval you are allowed for anterior segment surgery?
Sir, it has to be intervened as a comprehensive approach. If it is anterior segment tear, also corneal surgeon has to operate, and posterior segment has to operate. If it is a lid tear, oculoplasty has to operate on the same time. It is not like posterior segment has to be done separately, anterior segment has to be done separately, oculoplasty will see next day. Everything has to be intervened as soon as possible.
There is no time limit for that?
No. It's basically, I'm just dealing posterior segment, I showed this, but everything has to be dealt simultaneously.
So I had one question.
What systemic antibiotics do you use if the wound is bone deep in adults and in children?
Sir, I usually don't like to give systemic antibiotics unless I am suspecting end of at that time. Even for end of, since you are giving intravitreal antibiotics, it's antibiotics acting in the area. So systemic antibiotics, even in endophthalmitis studies, there is not much role of systemic antibiotics. So I prefer, usually do not advise to give systemic antibiotics.
Usually the trauma is concomitant. You will have a bone deep wound on the other side. So that's why it's hard for the eye to
if you are suspecting adnexal injury, lid tear or soft tissue injury or chance of infection, you can give systemic antibiotics. But just for this posterior segment injuries, systemic antibiotics doesn't have much role as such.
Yeah, I just differ. Like, in all trauma, I prefer to give IV antibiotics because I mean, eventually some of those will go for phthisis, and the medical legal point of view, I think if you are safe, if you give systemic IV antibiotics, and I prefer to start with cefuroxime. I mean, the most common cause is GNP, gram negative bacilli. So cefuroxime, I mean cephalosporins primarily.
Yeah, you can.
Yeah. Then, like now, Dr. Soni has asked to know. Actually, I prefer to exercise iris if it is more than 6 hours because ischemic iris no can cause endophthalmitis, and this is very difficult to treat post-traumatic endophthalmitis rather than this thing. I mean, that's what I feel. I don't know what others are doing.
Usually we are not,
Yeah.
now we are not exercising.
I can one last question for
Yeah.
both Anubhav sir and Madhika. Sometimes in these trauma, we may not even be able to find the muscle sometimes. Even before we disinsert it, we don't know where the muscle has gone. So how do you approach such a case? Like if you have to go fishing for the muscle, it has already been.
No, I will prefer to take the two sutures on the two muscle end carefully. You should not take one suture, and both sutures has to be kept carefully. If you have disinserted the muscle with two sutures exposing, there are very less chances that you will miss it. If already missed,
Yeah.
then you have to pray to God.
No, it's actually in fresh traumas. If you see a lost muscle, if you just follow the track of the muscle, it will be there. If it's a fresh trauma, if it is more than 6 hours or more than one day, then it is literally difficult.
It's
Have to do
edematous
a-
tissue and
yeah.
inflamed tissue. It's difficult to identify it.
Lost muscle is like
Thank you, sir.